Okay, we're covering Chapter 7, which is the cardiovascular system in your pathology class. Oops, sorry. The outline of the cardiovascular system, we're going to cover the physiology, the congenital heart diseases, acquired vascular diseases, valvular disease, pericardial effusion, and venous disease. Here are your chapter objectives. Make sure that you can define these. Here are your key terms. Make sure you know your key terms. Okay, so the heart, lot to it. So when we are looking at the blood flow through the heart, and you will need to know your blood flow through the heart, you have your superior and your inferior vena cava. And what they do is that brings deoxygenated blood back to the heart to get reoxygenated. So you have your inferior here and your superior vena cava coming into your right atrium. So this is your right atrium, which goes through, drops down into through the tricuspid valve into the right ventricle. The right ventricle pumps the deoxygenated blood through the pulmonary or we call it the pulmonary valve, but the pulmonary semilunar valve is technically correct. So it comes up through the pulmonary semilunar valve into the pulmonary trunk, which goes right and left. It bifurcates, and you have the left pulmonary artery and the right pulmonary artery. And as you remember, the pulmonary arteries are carrying deoxygenated blood. It's backwards from the rest of the body. So pulmonary arteries, deoxygenated blood coming off of the right ventricle. You have your pulmonary veins in the back here. So here's the right and here is the left. So your pulmonary veins are bringing back oxygenated blood into your left atrium. And then it falls through the left atrium in through your mitral or your bicuspid valve. Either way, I don't care which answer you use. And then it drops into your left ventricle. So your left ventricle then propels the blood out to your body through the aortic semilunar valve. And it goes up your ascending aorta, across and back down your descending. So that's how the blood flows through the heart. It's important that you are able to list that. Looking here at this heart, so we come in superior and inferior vena cava into the right atrium through the tricuspid valve into the right ventricle, up through the pulmonary semilunar valve, up through the pulmonary trunks to the left and the right pulmonary arteries, coming back through the pulmonary veins. Here's your left, here's your right, into the right atrium through your mitral valve or bicuspid, into your left ventricle, and up and out your aortic semilunar valve to your ascending aorta to your descending aorta. So the physiology. So the function of the cardiovascular system is to maintain an adequate supply of blood to all the tissues of the body. So this is accomplished by the heartbeat, and the heart rate is controlled by your autonomic nervous system. So some of the diseases, congenital heart diseases, and you will see this in some of the patients that come through. The left to right shunt, Tarot of Fallot, and the Coarctation of the Aorta. So we have the left to right shunts first. So they're the most common, as all genetic cardiac lesions. They permit mixing of the blood in the systemic and pulmonary circulation, so the lungs become overwhelmed with blood. This is because blood is proficiently shunt from the high pressure system circulation to relatively low pressure pulmonary circulation. So the defect size and pressure differences control the magnitude of the shunt, and a lot of people have surgery to have that closed. So there's arterial septal defects, which is the most common, where the two atria are communicating. There's the ventricular septal defect, and that's kind of a problem because you have high velocity blood coming out of the left ventricle that's going into the right ventricle instead of up the aorta. And there's the patent ductus arteriosus, and it's a remnant of a fatal circulation. So you have here your arterial septal defect of the chest x-ray. So here you can see we have some ballooning right there. So the frontal projection of the chest demonstrates cardiomegaly. So this heart is enlarged. The way that you measure a heart is you take the diameter of the heart against one side of a lung field. So if you measure here to here, it needs to be smaller than the spinous processes to the edge of the lung field there. So we have cardiomegaly along with increased pulmonary vascularity reflecting left to right shunt. So a small aortic knob, so that's the white arrow. So this is your aortic knob right there, and a descending aorta, so the smaller knob, arrows here are dwarfed by a large pulmonary outflow tract. So this is your pulmonary outflow. So it is really big. Your hilum should not be that big. All right, and here you can see on ultrasound we have the atrial septal defect and we have a ventricular defect. So you can see here the right ventricle and the left ventricle, and there's an opening. And here you have, I have no idea. I'm not ultrasound. It looks like there's a defect right here in the wall. All right, so so this one here is your cardiomegaly. So look how large this heart is. Oh my gosh. With left atrium, left ventricle, and central pulmonary arteries. So you can see there's a really thickened hilum here. You can't even see the knob on this patient. So there's also diffuse pulmonary vascularity. And B is another patient with an aortogram. So this is aortogram. Shows patency of the ductus arteriosus. So let's see, right there. So it's communicating with the heart. So that's not good. All right. So Tetralogy of Fallot is most common cause of cyanotic congenital heart disease. So remember what cyanosis is, so the blue color. It consists of 4 tetra abnormalities. So this is an important thing. So it has high ventricle septal defect, has pulmonary stenosis, it has overriding of the aortic orifice above the ventricular defect, and a right ventricular hypertrophy. So when we're looking at a chest x-ray, this one has characteristics of lateral displacement and upward tilting of the prominent cardiac apex. So here is the heart. So you can see that the heart normally lies in this plane here. So we've got tilting of the heart, so it's more lateral, so it's sideways. It's going this way instead of this way. There's also decreased pulmonary vascularity and a flat pulmonary outflow tract. So you can see there's not, in the hilum, you don't really see any pulmonary arteries or veins here. So that's decreased. So coarctation of the aorta is narrowing or constriction of the aorta. It commonly occurs just beyond the branching of the blood vessels to the head and the arms. The classic sign is normal blood pressure in the arms, but very low in the legs. This is most frequently cause of hypertension in children. So looking here, this is an MRI. It's actually looking like an MRA that we're getting ready to inject. So here's the heart here. So this is the heart and the chambers. And then coming up and around, this is your aorta. So this is starting your descending aorta. And you can see that there's a defect right here. So it's making this very narrow. And this is enlarged here. So these are enlarged vessels trying to accommodate the blood flow that's being restricted here. Oh, blank screen. Love that. All right, looking here, so in A, there's notching of the 4th through the 7th posterior ribs. A plain chest x-ray in B demonstrates a figure 3 sign, so the arrow pointing to the center, upper center. So you can see there's like a little notch there. So that's one of the things you'll read about it in your book. The upper bulge represents peristenotic dilatation. Lower bulge represents poststenotic dilatation. And in C, the esophagram demonstrates reverse figure 3 sign, arrows pointing to its center. So it has like the number 3, and you can see in the center there. All right. Acquired vascular diseases. So there's coronary artery disease, congestive heart failure, pulmonary edema, hypertension, hypertensive heart disease, aneurysm, traumatic rupture of the aorta, dissection of the aorta, atherosclerosis, thrombus, and embolism. So all of this should sound familiar just from being in this program. We talk about all of this. So coronary artery disease is the narrowing of the lumen of one or more coronary arteries. The most common cause is atherosclerosis, which is a deposit of fatty material on the inner arterial walls. It results in oxygen deprivation of the myocardium, which is the heart muscle, right? And ischemia of the heart. So with the decreased blood flow and nutrients, the heart muscle starts to die. So predisposing factors to coronary artery disease, you already know this: hypertension, obesity, smoking, high cholesterol diet, and lack of exercise. Oh boy. So this is what it looks like. So this is doing an angiogram. So you can see here coming down right there, we're not really seeing contrast flow through there, right? There's a narrowing, so it's just barely leaking through. So that right there is coronary artery disease, and that needs to be opened up right away. We can see here, let's see, comparison of conventional angiograms with a contrast-enhanced CT angiogram of a patient. So A, here is the cranial projection from a coronary angio, shows the left anterior descending LAD and circumflex arteries. And here on CT volume rendering, it's anterior, posterior, and cranial projection shows the left main coronary artery and its branches, the left superior descending, so the LAD, and the circumflex and coronary arteries. So this is showing you the difference. Same layout, so you have your circumflex and your LAD, and your circumflex and your LAD. What the cool thing about CT is we can actually do a fly-through, what we call fly-through, where I can dissect this and then look through the vessel. I can put like, it's almost like putting a camera in there and looking on the inside of the vessel. It's pretty cool. Congestive heart failure, so CHF, you'll see that on your orders all the time, refers to the inability of the heart to propel blood at a rate and volume sufficient to provide adequate supplies to the tissue, such as oxygen and nutrients, and to carry away old blood. So causes of CHF include intrinsic cardiac abnormality, hypertension, and any obstructive process that abnormally increases the peripheral resistance to blood flow. So if someone has advanced stage COPD, the blood can't exchange in the lungs, and that can lead to CHF also. So here you can see how there is, this is left-sided failure, so there's diffuse pericardial alveolar density. So we've got all kinds of densities here. And so this is congestive left heart failure. Right heart failure, patients usually have swelling in the ankles and the feet. So right-sided heart failure, you can see the difference, how different it looks compared to here. So what we're looking at is primary pulmonary hypertension to show pronounced globular cardiomegaly with prominence of the pulmonary trunk and central pulmonary arteries here. Peripheral pulmonary vascularity is strictly reduced, so there's not a lot going out to the out periphery here. So there's the right ventricular enlargement has obliterated airspace on the lateral, so you can see how large this heart is here. All right, pulmonary edema. So it's an accumulation of fluid in the extravascular pulmonary tissues. Its most common cause is elevation of the pulmonary venous pressure. It's usually due to left-sided heart failure. It may also be caused by pulmonary venous obstruction or lymphatic blockage. Other causes, uremia, narcotic overdose, I've seen that. Exposure to fumes, yes. Excessive oxygen, so if you give someone too much oxygen, this can happen. High altitudes can do it. Fat embolism, adult respiratory distress, and neurological abnormalities. So interstitial pulmonary edema, so the edema fluid is in the interstitial space, causing loss of normal sharp definitions of the pulmonary vascular markings and perihilar haze. So at the bases, notice the thin horizontal lines of increased density, which represent fluid. So there's lines down here, which is fluid. So that's all fluid in there. Sorry, it's a blurry picture. All right, so here, this is this is the butterfly pattern of severe pulmonary edema. If I saw this, I'd be very concerned for the patient. I'd show this to a radiologist immediately. So diffuse bilateral symmetric infiltrations of the central portion of the lungs along relatively sparing of the peripheral produces a butterfly pattern. So it looks like butterfly wings. So here's your wings on the outside. This patient's very sick. Hypertension, also called high blood pressure, right? It is the leading cause of stroke and CHF. Blood pressure is a function of cardiac output, so the amount of blood pumped per minute by the heart, and the total peripheral resistance, which reflects the condition of the walls of the blood vessels through the body. So renovascular hypertension, so here shows diminished size of the right kidney. So you can see from the measurements that this one is about 5 centimeters smaller. Here, if we did a renal angiogram, we can see here that there's stenosis on this right. So we have atrophy due to renal artery stenosis. And renal arteries, if there's any kind of stenosis, if we have out of control blood pressure, it's uncontrolled. We cannot get their blood pressure under control. It can be from the renal arteries. The renal arteries will control the blood pressure. So we'll do an angiogram to see if there's a stricture here. So this patient probably had increased blood pressure that was uncontrolled and atrophy of that kidney. So they can open that up and the patient usually will do well. So hypertensive heart disease. In hypertensive heart disease, long-standing high blood pressure causes narrowing of the systemic blood vessels and an increased resistance to blood flow. So left ventricle is forced to assume an increased workload, which initially causes hypertrophy, so double thickness of a normal wall. So hyper, remember, bigger, more. So here, hypertensive heart disease, so the lateral projection of the chest shows predominant left ventricle, so you can see how big this left ventricle is right there. And you can see here, this left ventricle, how large it is. All right. Aneurysm. So it is localized dilatation of an artery that is most commonly involves the aorta, especially in the abdomen. So there's secular aneurysm, involves only one side of the arterial wall, and there's fusiform aneurysm, is bulging of the entire circumference of the vessel wall. So looking here, we have an aneurysm. So here we've got ballooning on the outside, and you can see the aorta here, and we've got ballooning all the way around. This has been here a while. It's got some calcifications in it. It still is very large, makes me very nervous. And then coming down here, you can see how we're ballooning out, and it's coming down into the femoral also. So yikes. This right here is the ballooning also. So this is part of the aneurysm. Oh, this is a good one. So this is a fusiform aneurysm where the walls are calcified, so we can see it on a pelvic x-ray. So you can see all around here, this is an aneurysm. This is a ballooning. So this patient makes me very nervous. This patient might be dead. All right. This is the scariest kind, MRI of aortic aneurysm, so transverse scan, so an axial scan with cardiac gating allows us to see this thrombus within the lumen. This is on the ascending aorta, which is not good. Oh, is it ascending or descending? This is ascending here, but it's widened, and here's the descending. So we'd have to follow it up and see where it started. If it's coming off the left ventricle, that is pretty much the patient's going to die. There's nothing we can do. If it's past the left ventricle, past the semilunar valve, there's a chance that we can save this patient. A chance. I'm not saying it's good. I'm just saying there's a chance. All right, so this is a aortic stent that's been put in, so grafting. So they'll go in, and remember how Ryan talked about how you have to make sure that the renal arteries are not going to be cut off. So they put the sheath in to protect the aorta from rupturing. The aorta is very high pressure, so it could rupture at any time on patients. So, which leads us into the traumatic aortic rupture. A lot of people, this is what they die from in MBAs or any kind of fall. This is what's usually happened. So the traumatic aortic rupture is a potentially fatal complication of a closed chest trauma, such as rapid deceleration, like in an MBA. You have the seatbelt on, and the rapid deceleration can tear the aorta. Any kind of blast, so the guys fighting overseas and step on bombs, there you go, you got an aortic rupture. It can tear open, or just from the force of the blast can tear a aorta open. And compression, so any kind of crushing injury. Usually the aorta tears occur distally to the left subclavian at the site of the ductus arteriosus. So it can happen anywhere. You can have an aortic rupture anywhere. So they're not good. Chances of survival are very low. All right, so you can see here widening of the mediastinum with deviation of the nasogastric tube. So you can see the NG tube is not midline. You can see that. You can see all of this, and here there's fluid in here. This is all blood. So this patient bled out. So pretty sad. All right. Aortic dissection. So a dissection is, this is potentially life-threatening. We need to know about this right away and fix it before it ruptures or completely blocks off. So, so potential life-threatening condition in which the disruption of the edema or the inner layer permits blood to enter the wall of the aorta and separate the layers. It creates a true or false lumen in the aorta. The false lumen may form an aneurysm as a result of the high pressure in the systemic vascular system. So it's thinning, so it's separating the walls of the lumen, and blood's forming within that wall. So it's not as strong as it was. So you can get an aneurysm in that, and you can get a blood clot, and the blood clot can keep growing and actually cut off the flow. So it's most common with patients with arterial hypertension. You can have it from trauma or congenital defects such as Marfan's syndrome. So this is an ascending aorta. This is not good. So this is coming up off, and you can see the lumen right here. So we have a very thin lumen here with a lumen here. This is going to tear. This patient, I don't even think this patient is treatable. And then it's coming down the descending here. And the thing that scares me is we've got blood. This is free blood in here. So this is a tear. So this person is leaking. It's not completely leaking. I don't see any contrast in here, but it is leaking blood. So there is a hole somewhere. So this patient is in a very bad way. All right, so here there's a piece right here, right there. This is MRI, axial MRI of the heart. So you can see right there. Yikes. All right, something that's not as deadly, acutely deadly, but this will kill you, and this is what kills most Americans, atherosclerosis. So it's thickening, hardening, and loss of elasticity of the arterial wall. So fatty deposits develop in the edema, and it produces narrowing all the way to complete occlusion of a large to medium-sized arteries. The major cause of vascular disease in the extremities is atherosclerosis. So you can see it here. Right there, there's occlusion of the superficial femoral arteries. This looks more like the popliteal, but I'm not going to argue with them. So you can see it on both sides. Yikes, not good, not good. So little trace is getting through, but not by a lot. And you have the surrounding vessels, which are still feeding. Thrombus and embolism. So a thrombus is a clot. It's an intervascular clot. Causes stasis, let's see, injury, inflammation, any kind of blood clotting changes. An embolism is part or all of the thrombus that becomes detached from the vessel wall and enters the bloodstream. It lodges in other vessels, causing ischemia and occlusion. Okay, so there's emboli that are fat, which can be due to trauma. So there's fat within your bone marrow. So if you have a break, fat can get into your vessel and cause an occlusion. There's septic, which can be from infections, and there's air. So air bubbles introduced via trauma or surgery can, or injection. So please don't inject air in a patient, can cause this. So an acute embolic occlusion. So this here, you can see on the left renal artery, we have total occlusion. So you can see parts of the filling defects right there. So if you look closely, you'll see part of the filling defects. That's not good. Got to open that up. All right, valvular disease. There's different problems that you can have with your valves. One of them is from rheumatic heart disease. There's mitral valve stenosis, mitral insufficiency, aortic stenosis, aortic insufficiency, and an infective endocarditis. So rheumatic heart disease is from rheumatic fever. It is an autoimmune disease that results from a reaction of the patient's antibodies against antigens from previous streptococcal infections. So it damages heart valves, usually the mitral valve and aortic valves. Damaged valves either get stenotic, they open too narrowly, so they don't open all the way. They stay closed, semi-closed, or they become insufficient, so they do not close completely. So stenotic is where they don't open enough for the blood to go through. So if you have your mitral valve is not opening all the way, it's going to cause ballooning of what's just below it. So like your aortic valve, if that's failing, then you're going to have ballooning of your left ventricle. So insufficiency means it doesn't close completely. So instead of cutting off the blood from backflowing, it allows it to come back into the heart, and the heart pushes it out again, and then it goes up and comes right back in. So the heart is not very efficient at all. Mitral valve stenosis is almost always a complication from rheumatic disease, is a result from thickening of the valve by fibrous tissues, calcific deposits, or both. Blood flow is obstructed from leaving the left atrium and passing into the left ventricle during diastole. So it causes an increased pressure in the left atrium and enlargement of this chamber. So you can see here the left atrium right here. So the right ventricle causes obliteration. Let's see, whereas the left atrial enlargement produces convexity in the upper left border of the heart. So right here. So you can see this lump. It's like, what is this lump? That's what that is. So with mitral valve insufficiency is the most often caused, oh wait, is that what we just talked about? Oh, stenosis, insufficiency, I'm sorry. So mitral valve insufficiency is most often caused by rheumatic heart disease, so same thing. Rupture of the chordae tendineae, I'm not sure exactly how to say that. So dysfunction of the papillary muscles. Regurgitation of blood into the left atrium during ventricle systole. So when the heart is contracting, blood goes back up into the left atrium instead of going out through the aorta. It causes overfilling and dilatation of this chamber. It leads to decrease in ventricular stroke volume and cardiac output. So you can see here with insufficiency on A and B, so we have a frontal, which is interesting, we'll call it a PA, and a lateral. And we have gross cardiomegaly with enlargement of the left atrium and the left ventricle. So you can see how large here we're talking about. Note the striking double contour configuration. So here we're coming out like this, and we have the double contour on the frontal and elevation of the left mainstem bronchus. So it's up higher than it normally would be. Let's see. Right here. it's higher. Characteristic signs of left atrial enlargement. All right, aortic stenosis. Here we go again, rheumatic heart disease. So what's that cause from? Rheumatic fever. So congenital valvular deformity, especially of the bicuspid valve. Degeneration process of aging, so idiopathic calciphatic stenosis. The obstruction to the left ventricle outflow in the aortic stenosis increases the workload of the left ventricle. So here we've got the left ventricle. This picture just looks weird, doesn't it? Doesn't look like the heart's being pulled, like stretched. So we have the 3 leaflets of the aortic valve. So you can see here, aortic valve is calcified. So we have 1, 2, and 3. So this is your aortic valve. That does not look healthy. All right. So cause from rheumatic heart disease, syphilis, infective endocarditis, dissecting aneurysm, Marfan syndrome. So reflux of blood from the aorta during diastole causes volume overloading of the left ventricle and dilatation of this chamber. So here, aortic insufficiency, you can see on this, well, frontal chest, I'm not sure, we'll call it a PA, we'll giggle and call it a PA. So enlargement with downward and lateral displacement of the cardiac apex. So you see how low the apex is? So here's your diaphragm, and you can see it's coming down way low. So if you have a patient with aortic insufficiency, you're going to have to go pretty low. I mean, you're clipping the costophrenic angles off, so you clearly would need to get those on there, and you need to make sure that you've got all of the heart on there, okay? So notice the cardiac shadow extends below the dome of the left hemidiaphragm, and the ascending aorta is strikingly dilated. So you've got, this is your ascending right here. It's huge, suggestive of some underlying aortic stenosis. Yikes. All right, infective endocarditis. So infective endocarditis refers to the development of nodules or vegetations of the heart valves caused by deposits of bacteria or fungi. They're larger than rheumatic fever vegetation. So the vegetations of infective endocarditis are filled with bacteria. They tend to break apart easily and form septic emboli, which is not good. So infective endocarditis is demonstrated on an echo. So radiology really doesn't have a role in this. We can't see it, okay? Pericardial effusion, this is a big deal. So pericardial effusion is the accumulation of fluid within the pericardial space surrounding the heart. It can be from bacteria, viruses, neoplastic involvement, idiopathic pericardial effusion. It can also be from trauma. So rapid accumulation interferes with cardiac function because the increase of pericardial pressure. There was a patient that was hit square in the chest by a baseball, and the patient was brought to Palomar Medical Center, and the thoracic surgeon was in a case and couldn't leave the case. Trauma code was called. He couldn't get out of the case. Young kid died from pericardial effusion. All they had to do was stick a needle in there and drain the blood out. So what happens is the heart's trying to pump in this sac that has lubricant, and so to keep the heart from any friction when beating, well, he's hitting the chest, he had a tear, it was bleeding inside that sac, and as the blood accumulated in that sac, it compressed the heart to where the heart could not pump the blood because it was so restricted, so it was squished, so it could not pump. So this is a good picture of pericardial effusion. So the heart is probably teeny, teeny, teeny. So this is, the sac is pretty strong. And so the sac is not giving way and blood is accumulating. And as it bleeds and bleeds and bleeds, the heart is getting smaller and smaller and smaller and smaller to where the heart does not pump any further. You have to get a needle in there and you have to suck this blood out. You got to find out where it's bleeding to stop the bleeding. All right, so you can see here, great example. So here's the heart, and you can see the blood in the sac around the heart. So this is the heart muscle the darker gray line, and you can see that the heart is being compressed. We also have some blood backing up into the lung space here. So you can see the heart here, and you can see all the blood all the way around. And we've got an object of some sort, a catheter. They put a catheter in to drain the blood so that the heart can continue to beat. You can do all the chest compressions in the world, but if the heart is completely collapsed or squished, there is no way that the heart can propel blood through the body. So this is an emergency. These patients die fast. All right, so you can see here, this is a small one. We've got a little bit of pericardial fluid around and around here. All right, so venous disease, we have deep venous thrombosis and we have varicose veins. So DVT, deep venous thrombosis, DVT, primarily involves lower extremities. It's a major source of potentially fatal pulmonary embolism. So it can be from trauma, bacterial infections, prolonged bed rest, oral contraceptives. You say, what the heck, oral contraceptives? Yes. So what happens is women taking oral contraceptives, for some reason, the blood doesn't flow quite right. You get blood clots. They come up and lodge in the lungs. Pretty crazy. I've also seen some blood clots in the venous system of the brain, which is very rare. We see it with oral contraceptives and guys on steroids. We'll see blood clots in the venous system in the brain. So if there's a pulmonary embolism on a young patient, first thing we're going to check and see if they're on oral contraceptives. So if you're in CT and you're scanning and you see that there's a pulmonary embolism, you're going to ask if they're on contraceptives, because your radiologist is probably going to ask you. If they had a long flight, people who fly from Japan to here, or Australia here, and they're on oral contraceptives and they sat with their legs crossed, the blood will clot, and it'll, as soon as you get moving again, it'll go right up into the lungs and you have a pulmonary embolism, which can be life-threatening. All right, DVT may be the earliest symptom of a unsuspected malignancy of the pancreas, yikes, lung, or GI system. So here you can see, this is popliteal here, so you can see the filling defect of the clot. So a lot of times when you'll actually scan the lungs looking for pulmonary embolism, a PE, it'll look long and skinny like a worm. It's because it's in the venous system, so it is in a long, skinny vein. And you can see here the clot, the filling defect right there. So that's a clot. It's supposed to look like this, not like this. So we've got a clot right here, and you see the little worm-like, and a clot here. So not good. Varicose veins. So varicose veins are dilated, elongated, tortuous vessels that most commonly involve superficial veins of the leg, just under the skin. Of course, they look gorgeous. We all love varicose veins. So here's a lower extremity venogram showing multiple tortuous dilated venous structures. So look at all these varicose veins. Oh my goodness gracious. There's a lot of them. And you can see here, we've got varicose veins here, little round calcifications. Those are also varicose veins. Varicose veins in the rectum are called hemorrhoids. All right, that's it. That's all there is to it. Study up, make sure you read your chapter so you will do well on your quiz.